The government is throwing millions of South Africans a lifeline with the launch of a new antiretroviral treatment amid the release of the latest UNICEF HIV/AIDS statistics. Health Minister Dr. Zweli Mkhize on Wednesday launched the 3-in-1 ARV called TLD in KwaZulu-Natal, the country's worst-hit province.
The drug is expected to have fewer side effects and decrease the infection rates, which will help because, this will stem the tide of the epidemic. And that's a big question that we're asking right now. And in studio, we're joined by Editor-in-Chief of Bhekisisa Center for Health Journalism, Mia Malan. Mia, good morning, and thank you very much for joining us.
Good morning.
So, Mia, how does the TLD differ from the current antiretroviral treatment?
So, everyone who uses HIV treatment needs to use a combination of 3 drugs, and our government provides this in a 3-in-1 pill. And those are 3 different drugs that attacks the virus at different times of sort of infiltrating the body. Now, the drug that this dolutegravir, which is the name of the new drug, is replacing is something called efavirenz, that is part of that 3-in-1 combination. And what makes dolutegravir so great to introduce is the fact that it is so much more effective than efavirenz to bring down the amount of virus in the body of someone with HIV. And when you bring down, ARVs can bring down the amount of virus in someone's body to such low levels that it's scientifically impossible for them to transmit the virus to others. So if a drug can do this faster, it means that we will bring down the rate of new infections. This drug will also bring down the cost of HIV treatment by about 12% in the first year of use, studies have shown us. So it's great that we're introducing it. It took us a while and it's not entirely new. We have been using it as second-line treatment. That is the treatment that someone with HIV would use once the first-line treatment no longer works for them, when they've become resistant to those drugs. So we have been using it a little, but we had to wait for prices to go down. But more importantly, there's been a very big debate raging about the side effects of dolutegravir. Although it's far fewer than efavirenz, which could often make you hallucinate or have nightmares in the first few months of using it, it does have 2 important side effects. The one is weight gain. On average, women in South Africa, a study has shown, would gain about 5 kilograms, which is a consideration. But the side effect that has brought the most discussion, and that is why we took a while to introduce it more widely, is that in Botswana there was a study done on women using this drug, and it showed that there's a slight increased risk of women giving birth to babies with birth defects called neural tube defects. It's only an issue in the first 6 weeks of pregnancy. It's only when you conceive. And it's a small increased risk. It showed that if you're on other ARVs, the risk is about 1 out of 1,000 births. And if you're using dolutegravir, it's about 3 in 1,000 births. But that introduced a discussion that should women of childbearing age be using the drugs, or what kind of counseling should we give them? We should give them the power to decide whether it's good or bad for them, but are we able to give them good contraceptive counseling, because nurses are so stretched in clinics? And more importantly, are we able to give them contraceptive choice? Because at the moment, what often happens is women will go into a clinic and a nurse will just say, yes, the 3-month injection. So do we really give them a choice, and do we really empower them?
Mia, you've actually brought up so many issues in just that one answer alone. Let me just probe into something else. So when you speak about the different variations of drugs, can somebody switch between those 2? So for example, if you are a mother and you decide you're going to have a kid now, so in order to prevent mother-to-child transmission, you want to switch to a different kind of drug, for example, that will not increase your chances of having a birth defect. Can you do that? Is that recommended?
Yes, you can. So our ARV guidelines that the government has now introduced with a new availability of dolutegravir for first-line treatment says that anyone can use the dolutegravir combination, but it is important to provide someone with counseling and the risks of what are the risks, and that you should be able to use the other drug combination that contains efavirenz if you want to fall pregnant and you don't want to encounter that risk. But of course, then you have to put up with the side effects of efavirenz that might give you nightmares or depression in the first few months of using it. Those side effects eventually disappear, but in the first 3 to 6 months, they are an issue.
You spoke about trials in Botswana. Have you had any local trials in South Africa of the new drug?
So we have had trials, and that is the trial, it's called the advanced trial, that has shown the increase in weight gain. It has not shown a significant risk with birth defects, and there's also been other studies in Brazil where there were no risks shown for birth defects. But it doesn't mean that we can just ignore the Botswana risk. And you know why this has become such a big issue, is that when we test these drugs internationally, it's generally first tested in Europe. And in Europe, the part of the population that's affected most by HIV is very different from that in Africa. It's men who have sex with men. And in Africa, the virus is spreading the fastest among young women. So when it's tested among those men, they of course can't fall pregnant, and they don't necessarily show a weight gain or the same type of weight gain that women would. So it was only when we started to test it in Africa that we became aware of these risks, which shows us how important it is to test a drug in your own country and your own population.
Absolutely, and these are very, very pertinent points. You spoke now about young women being the most vulnerable. We also spoke yesterday in the show about the new HIV statistics. What do you think can be done to try and curb that? Because another issue, which you touched on yesterday, is the fact that men, especially men, let's say in their 30s, going up to 50, don't usually like to take treatment. But then they'll date younger women and they'll infect those younger women. So what can be done to make sure that men end up taking their treatment to prevent reinfection?
And is this where PrEP can become quite important for young women?
Absolutely, and that's such an important point that you've raised, because research in South Africa shows us that one of the most common ways for younger women to get HIV is from something that scientists call age-disparate sex. And that really means sex with someone 5 years and older than yourself, when there's not an equal power relationship. It's more a little bit like transactional sex, where the woman doesn't have that much negotiating power for safe sex, because there's generally something that she might receive in return. And also, you know, age introduces that relationship that's not so in equal power. So yes, you've mentioned PrEP, which is the scientific name for the HIV prevention pill. Absolutely, that is something that can definitely be used to prevent HIV. If you take that pill the same time, or if you take it once a day, it can really drastically reduce your chances. But studies have shown us that young women are not very good takers of that pill. So at the moment, there's research in KwaZulu-Natal going on that looks at, can you give long-acting HIV prevention medication? So can you give an injection that could eventually, for instance, be combined with contraception that someone doesn't have to take each day? But you've introduced an important issue, that how can we get men to take their treatment that will essentially prevent them from transmitting the virus? Studies around the world, not just in South Africa, show us that men always access treatment for whichever disease, on average later than women. Now, one of the reasons why women access it earlier is because they go to clinics for antenatal treatment. They fall pregnant, so they naturally have to go to a clinic far more often than a man, but also men tend to address their health issues just later than women.
In South Africa, for example, men don't even go for treatment. So let's say if I'm married to Googs, when she goes for her treatment, then I'll just be like, oh, let me take a pill as well. But it's really her prescription.
Yes, and it's not just, as I've mentioned, not just for HIV, it's generally for everything. And that is why figures show us that more men die of HIV than women, which is quite shocking because more women have HIV than men, but the women access treatment earlier. So when it comes to young women and HIV, the research that researchers really want to focus on at the moment is something that they call a biomedical intervention. So something like PrEP, but something like long-acting PrEP, because so that it's something that cuts out that decision or everyday decision that you have to make, or something that that allows you from a medical perspective, that it doesn't involve your decision or your negotiating power with a man, that it is something that can be a game changer. Researchers think it might be a game changer if they develop long-acting PrEP, because it would be so much easier to use. Because science, this has also done research on, are there like things that we can do to change behavior when it comes to age-disparate sex? And very, very few of those things have worked so far, because there's so much inequality in society. It's so hard to eliminate age-disparate sex, that a biomedical intervention might be something that could potentially be easier to use and also more effective.